Começando a gravação.
Pode começar, Juliano.
Olá, boa noite. Queremos dar boas-vindas mais uma vez a um novo programa de atualização científica da SBEM-DF. Hoje traremos o Dr. John Blezikian para falar sobre atualização do tratamento de osteoporose. Queria passar algumas instruções iniciais. A palestra será com tradução simultânea. Se vocês olharem aí na barra inferior ao lado direito de vocês, haverá um ícone que se assemelha a um globo terrestre. Ali tem 3 opções: um canal em inglês, para quem quiser ouvir em inglês, o áudio original, e o canal em português, para, obviamente, receber a tradução simultânea. Existe um outro ícone também nessa mesma barra inferior, que é do Q&A, Question and Answers. Solicitamos que as perguntas sejam feitas por essa via, escritas, e ao final da aula, a doutora Fernanda Salles, junto com o doutor João Lindolfo, vão moderar as perguntas aí. Então, as perguntas não devem ser feitas pelo bate-papo, mas sim pelo ícone de Question and Answer. Queria passar a palavra para o doutor João Lindolfo, nosso presidente, para iniciarmos nosso evento. Obrigado, boa noite.
Boa noite a todos, muito obrigado por estar aqui. A gente está vendo aqui o número de pessoas só aumentando. É um prazer muito grande estar aqui abrindo essa aula. Primeiro, por ter um número grande de pessoas, e segundo, por ter uma pessoa super amiga e uma pessoa que gosta muito do Brasil, já teve algumas vezes em Brasília, inclusive, que é uma pessoa extremamente agradável. Ele combina duas coisas que é praticamente impossível de combinar. Ele combina conhecimento e humildade. Então, é uma pessoa muito querida. A Fernanda vai fazer a apresentação dele, eu vou apresentar a Fernanda. A Fernanda é endocrinologista, é diretora da SBEM-DF, é médica do Sírio-Libanês também, é uma pessoa muito ativa dentro da nossa sociedade. Então, como o Dr. Juliano disse, ao final nós vamos ter a chance de fazer perguntas por escritos, e o Dr. John Blezikian vai tentar responder todas essas perguntas. Esse é o 10º evento nosso desse ano, da SBEM-DF. Nós temos mais 3 eventos que virão. Nós vamos ter um evento breve que é atualização no tratamento do uso do hormônio de crescimento. Depois nós temos casos difíceis em tireoide, e finalmente nós vamos ter um curso de osteometabolismo pediátrico. E aí encerramos o ano com 3 eventos muito bem sucedidos, cheio de público esse ano. Então, muito obrigado a vocês. Fernanda, a bola é sua.
Boa noite. Nós temos o prazer de ter hoje o Dr. John para dar uma aula de atualização em osteoporose. O Dr. John Blezikian, professor de medicina da Universidade de Silberberg, é vice-presidente do Colégio de Clínicos e Cirurgiões para Educação Internacional e Pesquisa da Universidade de Colômbia. A aula está realmente muito boa, espero que vocês aproveitem. Dr. John, quando você estiver pronto, pode começar a sua aula.
Okay, I think I will go. Can you see my screen?
Not yet, John.
Oh, sorry.
Not yet, ainda não.
Share screen.
Can you see it now?
Yes.
Now
yes.
we can see.
Okay, good. Okay. Well, thank you very much, Fernanda and João and Juliano. It's a great pleasure to participate in this program. Obviously, I wish I were in Brazil with you, but alas, we still can't move around the world the way we used to. But hopefully, this presentation will allow us to discuss the question of osteoanabolics. And the question I'm going to try to address is, are they ready for prime time? Now, having done that, my screen is not a... Okay. So these are my disclosures. We all know that there are 3 osteoanabolic agents available, varying from country to country, but we are going to discuss the 3, teriparatide, abaloparatide, and Remodeling. And when we think about osteoanabolic therapy, we think about individuals at high risk for an osteoporotic fracture. And high risk can be defined, as shown on this slide, as a very low T-score, less than -2.5, someone who's had a prior hip or vertebral fracture, or someone who has a FRAX index that is in the high risk category. There is another definition of high risk, and that is very high risk. And as you can see on this slide, these would be individuals with even lower T-scores, those who have had a fracture while they are on approved treatment, those with multiple vertebral fractures, severe vertebral fractures, and by FRAX, an even greater risk of a fracture. We also include high fall risk among those who are at very high risk. Now, very interestingly, most postmenopausal women will meet one or more of these guidelines for osteoanabolic therapy. But bear in mind as well that many of our anti-remodeling or anti-resorptive drugs are also approved for these high-risk individuals. I think this is something that can be discussed, but most of us would agree that for both anti-resorptive and osteoanabolic drugs, the benefits far outweigh the risks that we all know about. The decision to use an osteoanabolic or anti-resorptive drug takes into account convenience, cost, who's paying, the adverse event profile, and our judgment. And I would say our judgment is very important. It is not the science of our field, but the art of our field, and also consideration of the goals of therapy. Another important discussion point, and I'm going to spend a fair amount of time on this, is understanding how these drugs work to reduce fracture risk. And in fact, my presentation is going to focus on underappreciated secondary aspects of these drugs that may either mitigate or facilitate their ultimate actions. And as I like to do for my presentations, is to present questions. I'm not sure I'm going to answer them, but at least they will be subjects for discussion. So let's begin with the beginning, and that is in the early 1960s when we became aware of the bone remodeling cycle. And the bone remodeling cycle is shown in cartoon fashion here, and I've highlighted the initial phase, which is a period of bone resorption. And you can see these osteoclasts are digging this bone remodeling unit, and you know the sequence is over time, the bone remodeling unit is filled in with type 1 collagen and ultimately by mineralized tissue. But from a therapeutic point of view, the effect to inhibit bone resorption was initially the goal. And there was certainly good rationale for that, because in the 1960s, we understood, and later into the 70s and 80s, that we have 2 factors. 1, low bone density, and 2, high bone turnover. And these 2 factors are independent, each contributing to fracture risk, and high bone turnover or high remodeling independently contributes to fracture risk. And if you look at the balance of bone formation and bone resorption over the span of life, in the green part of this table is where we are either making more bone than losing bone, or are in some equilibrium until the age of about 45. But thereafter, you can see in the orange and then in the reddish pink parts, the timeline of aging now has bone resorption predominantly showing the fact. So it stands to reason, as we get into our middle or later years, and of obviously the time when osteoporosis is much more common, that it would seem logical to use agents that will prevent excessive bone resorption. And this story really took off in the late 1960s. I show you the trio of the bisphosphonate discoverers as it relates to osteoporosis. Professor Graham Russell, still very active in Oxford, England, and the late Herbie Fleisch and the late Dave Francis. And together, they published this article in Science pointing out that these compounds, the bisphosphonates, are very effective in inhibiting bone breakdown. And in this very famous paper, they even said these drugs, they called them diphosphonates, but they are bisphosphonates, might prove valuable in the treatment of osteoporosis and other human diseases that involve increased resorption of bone. And certainly we understand that to be the case. This is a model by which the bisphosphonates work. As they exchange with hydrogen, the molecule gets into the osteoclast, and depending on the bisphosphonate, they would impair the function of the osteoclast, or actually could render it completely inactive. So the anti-resorptives, starting with the bisphosphonates, are shown here. And in yellow, I indicate the drugs for which I think there is really good evidence that they are effective in reducing vertebral, non-vertebral, and hip fractures. And on this table, you can see estrogen, you can see 3 bisphosphonates, and you can see Dinosaumab as the drugs for which we have evidence for global efficacy. Now, let me speak a moment about Dinosaumab, which I think is a particularly interesting anti-resorptive agent. We know that Dinosaumab is an anti-rank ligand agent, rank ligand being a very potent cytokine that resorbs bone. And it was believed, and still is, that Dinosaumab works primarily as a rank ligand inhibitor. You know, the FREEDOM trial showed that this drug reduces non-vertebral, vertebral, and hip fractures in each of these areas in the blue. The reduction is significantly lower, greater than it is in the placebo shown in the orange. But what I would like to focus on in this presentation is the very interesting effect of continuous Dinosaumab therapy on cortical bone. This is a slide showing the distal third radius, and in blue showing the group that got Dinosaumab at the beginning of the study that had the 7-year extension. And in the white, you see the placebo group losing cortical bone, that is distal third radial bone. And then when the transition occurs to Dinosaumab after year 3, that loss is protected. And this is a very interesting observation, which I have been thinking about for a number of years. Why is it that Dinosaumab, different from all the other anti-resorptives, is able to preserve or actually increase cortical bone? In that FREEDOM trial, the extension period, which was after 3 years, I'm showing you the placebo arm of that extension study. And whether you look at the ultradistal radius or the cortical site, the 1/3 radius in the beginning, you can see at the transition from placebo to denosumab, there is a continuation of stability and then actually an increase in bone density of the distal 3rd radius. If you look at cortical porosity, in green is shown the denosumab arm, in yellow is shown the alendronate arm in a phase 2 trial, and in white is placebo. And you can see that the data, not quite significant, but there is a reduction in cortical porosity with only denosumab. This also comes to mind the very interesting study that Mike McClung published many, many years ago. This was another phase 2 trial, and I've circled the change in parathyroid hormone as a function of denosumab treatment. And in the yellow is the 60 milligram dose, and you can see that from baseline to the peak after about 1 month, there's an approximately doubling of endogenous parathyroid hormone. If you relate the change in parathyroid hormone to the reduction in cortical porosity on the right, you can see that for each nanoil increase in parathyroid hormone, there is actually a reduction in cortical porosity. And that is completely different from alendronate, which can also increase parathyroid hormone. But in this case, with the increase in parathyroid hormone, there's an increase in porosity. Now, how to explain this? I think one way to explain this is to look at this cartoon again and appreciate that with denosumab, parathyroid hormone levels go up. And we do know this. If you measure parathyroid hormone in your patients, you will see that they invariably go up. Now, given the mechanism of denosumab, which is to block rank ligand, and understanding that the catabolic effects of parathyroid hormone depend on rank ligand, with this not being functional because of denosumab, but with the increase in parathyroid hormone, what we may well see is parathyroid hormone acting in its other mode, which is an anabolic mode, an anti-sclerostin mode, leading to an increase in bone formation. So actually, one could look at denosumab as a dual agent. Primarily, it's an anti-resorptive, but its secondary effect is to increase parathyroid hormone, and that increase, because of the inhibition of rank ligand, actually facilitates the anti-resorptive actions of denosumab. I mentioned briefly that bisphosphonates can also increase parathyroid hormone, but only minimally, and we don't think that that has any clinical importance. Now, the transformative history of anti-resorptive therapy for osteoporosis is clear. Their use has altered the landscape of our field. We used to think it was futile to try to treat patients with osteoporosis, but with the anti-resorptives, we know that they can be highly effective and we can prevent the devastating consequences of osteoporosis. And of course, we've had discussions about benefits and risk, and I will not go into that tonight, but clearly I believe, and most of us do, that the benefits of therapy with the anti-resorptives clearly outweigh the very rare side effects that we have to deal with every once in a while, such as osteonecrosis of the jaw or atypical fracture. Now, moving on, another goal of therapy is not just to increase bone density and reduce fracture risk, but really appreciate the basic problem in osteoporosis, which is a deteriorated microstructure, as you can see on the right. The goal of an ideal therapy would be to reconstruct the skeleton and make this right-sided microstructural depiction of osteoporosis, if you could, make it resemble more that normal microstructure of non-osteoporotic bone. So from the year 2000 onwards, we began to think about this, and rather than emphasize increased bone resorption, to think about osteoanabolic therapy as a way of dealing with reduced bone formation, which is a part of the abnormal dynamics of bone remodeling in osteoporosis. So the challenge is to take this broken down piece of bone and to transform it into better bone, and perhaps with the ideal osteoanabolic, which we don't have at this point, one could completely restore the microstructural abnormality in osteoporosis. The ideal osteoanabolic agent would look like this. It would stimulate bone formation and continuously. There would be no increase in bone resorption, and there would be no waning of the effect of the drug. Again, obviously, we don't have such a perfect drug. Bone forming agents don't continue their effects for an indefinite period of time. One of the ironies of our field, as we think about osteoanabolic therapy, is that it began with a drug that we thought did the opposite. Parathyroid hormone is bad for bones. And as endocrinologists, we know this. On the left is the famous sea captain, Charles Martel. I show this slide when I talk about primary hyperparathyroidism. And you can see what primary hyperparathyroidism did to the skeleton of this man a few years later. On the right are radiographs of a patient I took care of who had the X-ray findings of primary hyperparathyroidism, again, showing the devastating potential causing the salt and pepper erosions of the skull, the distal third clavicle you can't even see, the subperiosteal bone resorption of the distal phalanges, and the pelvis of this woman is riddled with osteitis fibrosis cystica. Now, we have different presentations of hyperparathyroidism, of course, but even when it presents as an asymptomatic disorder, we have clear evidence that parathyroid hormone is bad for bones. So the real transformative thought here, that is, how do you take a hormone like PTH and use it as a drug that is an osteoanabolic for osteoporosis? And the real breakthrough was the appreciation that when PTH is given in low dose daily, rather than it being a catabolic effect, it is showing itself to be an anabolic agent. Now, when I say parathyroid hormone, of course, I don't really mean parathyroid hormone. I mean teriparatide, which is the amino terminal fragment of parathyroid hormone that contains all the classical biological activities. The classic paper by Robert Neer, now 20 years old, showed that teriparatide reduces new vertebral fractures and non-vertebral fractures very significantly. And also getting to the goal of therapy, looking at these micro architectural depictions from Dr. David Dempster, you can see how the microstructure of bone is improved, both with regard to the cortical and to the trabecular compartments. And over the years, we know that teriparatide has many other effects to show its efficacy in those who have severe fractures, multiple fractures, glucocorticoid-induced osteoporosis, as well as in osteoporosis in men. Now, let me move on to the mechanisms by which these osteoanabolics might be effective. They obviously build up bone. And as nicely illustrated by Dr. David Dempster, my colleague, who has conceived of 3 different types of osteoanabolic activity. There is what is called remodeling-based bone formation, and that is taking the bone remodeling unit, and when it is filled, if you will, more so than it needs to. And this overage here is that anabolic feature against a backdrop of remodeling. This is called remodeling-based bone formation. There is also a concept of modeling-based bone formation in which bone is formed on quiescent surfaces. There's no remodeling system here. Bone is just formed on lining cells. And this is a feature of the growing skeleton. But in the presence of a drug like teriparatide, there is an element of modeling-based bone formation. And then the third mechanism is a rather new one, and that is to take this bone remodeling unit and now not just getting filled a little bit overage, but there is an extension onto quiescent surfaces. And David has talked about this as overflow modeling-based or overflow remodeling-based bone formation. And Dr. Dempster has done some interesting studies to try to determine which of these 3 different mechanisms might predominate in the context of teriparatide. And this study looked at subjects who were going to have a hip replacement. They were treated with teriparatide. They did not have osteoporose. And then they were given tetracycline afterwards. And by the dynamic histomorphometry, what was shown was that remodeling-based bone formation and overflow remodeling-based bone formation, both in the cancellous envelope and the endocortical envelope, was greater in the group that got teriparatide versus the group that got placebo. There wasn't a significant effect on modeling-based bone formation, but there was a difference between the teriparatide group and the placebo group. So looking at this cartoon again, we would say that teriparatide primarily is an osteoanabolic by affecting remodeling-based bone formation and overflow modeling-based bone formation. Now, with regard to this cartoon, teriparatide stimulates bone formation, but ultimately, after a year or 2, bone formation markers fall. And in addition, bone resorption markers increase. And the time between the primary stimulation of bone formation and the secondary stimulation of bone resorption, we have called the anabolic window. And as you can see here, the anabolic window stays open only for a relatively short period of time. It is believed that this increase in bone resorption is limiting the osteoanabolic potential of parathyroid hormone. Let me make a comment on the safety of PTH. After 20 years of use worldwide, with over 3 million individuals exposed, with a careful surveillance study, in fact, this was published in the JBMR just in the fall of last year, where there was no signal of osteosarcoma after 15 years of careful surveillance, to the point where the FDA in the United States in November removed the black box warning for the branded product. The black box warning in the US still exists for generic teriparatide as well as for abaloparatide, but we expect that will change in the near future. So let me then look at teriparatide in this way. It's a bone-forming agent for sure, but it also stimulates bone resorption. And so the bone formation to bone resorption ratio clearly favors bone formation. Filling this table in, now we have teriparatide using parathyroid hormone in two ways. One, as an anabolic agent, but later, when parathyroid hormone or teriparatide stimulates bone resorption, we have a mitigation of that primary action, and thus restricting its potential as a pure osteoanabolic. Let me move now to abaloparatide. Abaloparatide is an analog of PTHrP, and as you can see in this cartoon, PTHrP in the middle and abaloparatide in the bottom look very much alike. These are amino acid sequences as compared to teriparatide. What is different about abaloparatide in reference to PTHrP are the amino acids depicted in these yellow boxes. And these yellow boxes give a different linear sequence of abaloparatide in comparison to PTHrP in such a way as to stimulate or realize a greater osteoanabolic potential than is the case with PTHrP. And the thinking here is that abaloparatide is binding more selectively to a configuration of the PTHrP receptor, that is the RG configuration, that allows it to be a greater osteoanabolic agent. Now, the data for this come from binding studies. On the left is the RG configuration. And look, comparing abaloparatide with teriparatide, there really isn't very much of a difference. But if you look at the R0, which is the less favorable conformation of the PTHrP receptor, you can see that abaloparatide has much reduced affinity. And this would then suggest that the ratio of binding of abaloparatide to these two conformations of the PTHrP receptor would favor RG, or the anabolic state. And this has been shown again in this cartoon. By greater binding to RG, there is a burst of cyclic AMP, a very sharp peak, that unmasks the anabolic effect to a much greater extent than teriparatide, that binds more equally to the R0 and the RG conformation, giving a more prolonged stimulation of cyclic AMP and a more equivalent stimulation of osteoblasts and osteoclasts. Now, getting back to the mechanism, this again is work from Dr. David Dempster, in which he's looked at these three envelopes of bone as it relates to abaloparatide. And in the white parts of these bars, in these different envelopes, are shown effects of abaloparatide to be a modeling-based agent as opposed to a remodeling-based agent. And in fact, the data would favor abaloparatide actually utilizing all three osteoanabolic mechanisms as shown in this cartoon. Now, the abaloparatide clinical trial had a placebo compared to abaloparatide, and then an open label compared with teriparatide. Looking at the lumbar spine, bone density improves similarly with these two anabolics, and new vertebral fractures are reduced on the right, as you can see, equivalently well. Looking at the hip regions, the total hip and the femoral neck, in orange is abaloparatide, in green is teriparatide, and you can see that abaloparatide is stimulating increases in bone density earlier and to a greater extent than teriparatide. And in this cartoon, in this study, there seemed to be perhaps a greater effect, although that hasn't been shown conclusively, to reduce non-vertebral fractures and clinical fractures. but clearly these reductions are seen. And looking more specifically at non-vertebral fractures, in the arrow you can see abaloperitide separating itself from placebo and teriparatide very, very quickly after the administration has begun. The active extend trial took the group that was shown on the left after 18 months, and the group that got placebo or abaloperitide was transitioned to alendronate. The group that got teriparatide did not participate in the study thereafter. But looking at this extension trial with regard to radiographic vertebral fractures, non-vertebral fractures, clinical fractures, and major osteoporotic fractures, you can see that both in terms of the first phase of the study on the left, or the second phase of the study on the right, or together on the right, the group that got abaloperitide has a much greater effect to reduce new vertebral fractures, whether it is studied alone in the first 18 months, or even when placebo is transitioned to alendronate. Nevertheless, the prior use of abaloperitide gives it a much greater effect. And looking at this in terms of vertebral fractures, non-vertebral fractures, all clinical fractures, as well as major osteoporotic fractures, the extension study clearly gives a greater efficacy for abaloperitide. Now, a very interesting aspect of abaloperitide relates to its effect on bone turnover markers. And I show you from this study comparing P1NP, which is a bone formation marker on the left, with the serum CTX, a bone resorption marker on the right, looking at teriparatide in blue or abaloperitide in orange. Both drugs seem to stimulate bone formation equally well, at least at the beginning. But in terms of CTX, abaloperitide is much less effective in stimulating bone resorption than is teriparatide. And then if you go back to this cartoon of the anabolic window, since abaloperitide doesn't seem to stimulate bone resorption to the same degree, you have a reduction in the effect to stimulate bone resorption. And if you will, you have a widening of the anabolic window. That mitigation effect of the increase in bone resorption with this anabolic is not as great as with teriparatide. A summary of these two agents is shown here. Abaloperitide does not require a refrigeration after it is used. It is a daily injectable, as is teriparatide. The dosage is 80 micrograms versus 20 micrograms. In the United States, teriparatide branded product has no time limit anymore. It can be used indefinitely, while the generic and abaloperitide still has the wording of 2 years. And also the black box warning is still applicable for the generic and the abaloperitide product. So looking at abaloperitide in comparison with teriparatide, since there's a lesser increase in bone resorption, the ratio between bone formation and bone resorption favors bone resorption to a greater degree with abaloperitide than with teriparatide, and thus one could think of abaloperitide as a stronger osteoanabolic. And now filling in this table that looks at the dual actions of these drugs, we have abaloperitide now working as a bone resorbing agent after a while, but not to nearly the same extent. Thus, the mitigation of the primary action is not as great as with teriparatide. Let me move now to Remodeling. You all know about Remodeling. The way this therapy was developed was based on clues of a very rare set of diseases having to do with the sclerostin gene. They are sclerosteosis or Van Boeken's disease. And in the homozygous form of these two very, very rare diseases, these individuals accrue bone for the rest of their lives. They never break their bones, but they have major neurological sequelae as the excess bone formation causes effects on many cranial nerves. But the clue was not so much the homozygous disorder of the absence of the sclerostin gene, but the heterozygote carriers who also had high bone density, did not have fractures, but they didn't suffer from the long-term neurological sequelae. And this led to the idea that maybe an anti-sclerostin agent might allow the anabolic signaling pathway, Wnt, that is the pathway that sclerostin interferes with, greater access. So let me show you this cartoon that might explain it a little better. Under usual circumstances, we have Wnt interacting with its transcription factors, LRP5, 6, LRP4, and that then leads to a protection of beta-catenin in the cytoplasm, allowing it to gain entry into the nucleus where it serves as an anabolic factor. Now, this uncontrolled system is what is the case when there's no sclerostin around, but there usually is sclerostin around. And by having sclerostin interfere with Wnt signaling, there is a mitigation of this anabolic effect of Wnt. And now let us consider how the antibody against sclerostin would work. Well, what it would do is it would bind sclerostin and allow Wnt to get greater access to its transcription factors. And then you can see the effects in the cytoplasm and allowing the Wnt pathway to express itself to a greater degree in the presence of this anti-sclerostin antibody. The pivotal trial published by Felicia Cosman now about 5 years ago looked at Remodeling against placebo as a monthly injection, actually more than one per month. There were 3 injections in the original trial versus placebo for 12 months only, followed by Dinosaumab. And this slide taken from her work, as the arrows show the 12-month effect of Remodeling. On the left upper, you see a huge 13.3% gain in bone density at the lumbar spine. And on the upper right, almost a 7% gain at the total hip and a 5% gain at the femoral neck after only 1 year. The efficacy of this drug in terms of vertebral and clinical fractures after 12 months is clear. Lesser new vertebral fractures and clinical fractures, and after 24 months with the transition to Dinosaumab, new vertebral fractures were still reduced in the group that got Remodeling. The other important clinical trial called ARCH was published by Ken Sag. This was a positive control trial, not against placebo now, but against alendronate for 12 months, followed in both cases by alendronate for another 12 months. The first 12 months show the same major gains with Remodeling at the lumbar spine and the total hip. And I will call your attention later to changes in bone turnover markers. Again, this positive control study showed that Remodeling against alendronate had much greater efficacy. You can see the blue versus the pink in terms of new vertebral fractures, clinical fractures, non-vertebral fractures, and hip fractures. And work done by Michael Minsky, both in cynomolgus monkeys at the top, and by Chabassou in the lumbar vertebrae from humans, you can see that there are major effects on bone modeling with tetracycline labeling being found on all the surfaces, a very marked osteoanabolic agent. And Chabasu has shown also that the microstructure of bone that we spoke about earlier is markedly improved in the group that got romosozumab versus the group that got placebo. Now, although we think of romosozumab as a major anabolic agent, and this is a rat study in green showing that all three envelopes of bone are markedly stimulated in this overrectomized rat treated with the sclerostin antibody. The other point of this drug is that it's an anti-resorptive. Looking at the osteoclast surface, you can see in green that there's a marked reduction versus placebo, and certainly relative to the overrectomized control. So even from the early animal studies, it should have been clear that this drug had a dual action. It was both osteoanabolic and anti-resorptive. And now let me move to the very interesting effects on bone turnover. There's a marked stimulation of bone formation as shown by P1NP, but it is very transient. And by 12 months, actually the P1NP level is below baseline. And on the right, you can see that the CTX level drops by about 50%, never reaches baseline and falls some more. So this is very, very different from teriparatide and from abaloparatide, suggesting that this drug is simultaneously stimulating bone formation and inhibiting bone resorption. And looking at this window again, we now have a different view. We have an anabolic effect for sure, with an increase in bone formation, but we have an anti-resorptive effect. Now, compare that with teriparatide. Looks completely different. And one would expect that romosozumab would be a much more potent anabolic agent than teriparatide. The structure study compared romosozumab with teriparatide, in fact, and looking at bone density of the total hip, femoral neck, and lumbar spine, that expectation is clearly seen with romosozumab showing much greater increases in bone density at these three sites in comparison to teriparatide. So it would appear that these dual actions of romosozumab is helping to account for the greater anabolic window and the greater effect of romosozumab on bone density. Clearly, romosozumab is a modeling-based drug when we think of it as an osteoanabolic. I think many of you know that in the ARCH trial, but not in the FRAME trial, but the ARCH trial that had the positive control with alendronate, there was an imbalance in MACE events. Overall, there were greater MACE events, and specifically with regard to myocardial infarction, stroke, or cardiovascular death, there was an imbalance when Romo was compared to alendronate, and the hazard ratio was 1.87, clearly greater than 1 and significant. And this has led to the black box warning of a possible increase in MACE-related events. We do not use romosozumab in someone who's had an MI or a stroke within a year, and we would obviously stop the drug if that event were to occur while the patient was being treated with romosozumab. I want to point out, however, that the FRAME trial, which had the placebo control, there was no imbalance in any of these MACE-related events, and the hazard ratio crossed 1. So we have a dilemma here as to why it was seen in one study and not seen in the other study. But this is the way it is, and we have to at least deal with it until we have more clarifying data. So mechanisms of osteoanabolic agents, we're filling in this table now with romosozumab stimulating bone formation reducing bone resorption, and the ratio between bone formation and bone resorption is clearly the greatest. We would say by mechanism, this is a modeling-based and an anti-resorptive agent. And again, this notion of a dual action drug, Remodeling clearly is a dual action drug. It's an osteoanabolic, but its secondary effect is as an anti-resorptive. And this secondary effect is actually an effect to facilitate the primary action, much in the way as we talked about Dinosaumab's effect to increase PTH. So about to end my talk, and hopefully there will be time for a Q&A. Anti-resorptive and osteoanabolic drugs may contain within their own pathways of action or by stimulating other endogenous systems, a means to mitigate or facilitate their primary actions. Now, getting back to therapeutic guidelines, the Endocrine Society has guidelines in those who are at very high risk. The ACE has guidelines for those who are at very high risk, and we've talked about that. And you'll see on the right, anabolic therapy now is part of the choice that we have to make in those individuals who are at very high or very high risk. Obviously, we have bisphosphonate in the mix as well as Dinosaumab. So let me conclude. Rebuilding bone microstructure has emerged in time with 3 anabolic agents as a seminal element of our therapeutics. The chronology of anti-resorptive drug development and their lower cost has given them primacy in therapeutic decision-making, but the 3 osteoanabolic drugs present clear advantages in terms of their therapeutic goals, which is to improve skeletal microstructure. I think they should be considered in patients who meet guidelines if the drug's adverse event profile does not present concerns. So to answer the question, are osteoanabolics ready for prime time? I think I would answer simply with one word: yes. So let me end at this point and wish you all the very best at this very difficult time. I want to thank you very much for your attention. And I think we could have Q&A now, if I can stop sharing my screen, and we can open it up for questions.
Thank you very much, John. Outstanding lecture, as always. We are waiting for the first questions. Fernanda, a bola é sua.
Dr. John, muito obrigada pela aula, excelente. Para começar as perguntas, a gente tem uma pergunta da doutora Cristiane, e ela pergunta qual a melhor sequência terapêutica a ser usada e por quanto tempo cada agente.
Yeah, well, Cristiano, thank you for that question. And yes, you know, it's a very difficult question, Cristiano. If we had our choice and there were not factors like cost, convenience factors, a patient who has in the category of very high risk, the logic here is to use an osteoanabolic as the first line agent. And then we would follow it on with an anti-resorptive. That's in a perfect world. And I say that, you know, if the osteoanabolics were developed before the anti-resorptives, there would be no question. Of course, we would all do this, but we don't have that chronology. We have a different chronology. Cristiano, your other question is how long? You know, it's a very good question. And particularly in the United States, where we could use teriparatide, you know, more than 2 years, but I don't use it more than 2 years because it's not going to be effective forever. And so how I decide when to transition You know, and I'm maybe not a lot of you agree with this, but I find that bone turnover markers are very, very helpful. And when those bone turnover markers begin to drop, and it sometimes happens after a year with teriparatide or abaloparatide, and mostly after 2 years, that would be my signal to switch to an anti-resorptive.
Excelente, doutor. Nós temos mais uma pergunta do Dr. Rafael. O Dr. Rafael Lobo pergunta: o Remodeling poderia ter um papel na terapia da osteoporose em pacientes com mieloma múltiplo?
Oh, wonderful question. You know, I've never heard that question before, but let me think about it. My first answer is no. I don't think I want to use Remodeling in myeloma. I understand your question because obviously myeloma is a excess bone resorption, but also in myeloma, there's a problem with bone formation. So you could think very logically that a drug like Remodeling would be perfect. It will stimulate that inhibited bone formation that is characteristic of myeloma, and also it would block bone resorption, which is also characteristic of myeloma. The reason why I would be worried is the whether there might be some spillover of that anabolic effect on the Wnt pathway to, and we know that that can be an oncogenic pathway as well. So I don't think I would want to chance that risk. And I think we would probably be better advised not to use the Remodeling, even though I agree it's a great idea, but I think we probably wouldn't want to do that.
Excelente. Tem muitas pessoas dando parabéns pela aula. O Dr. Francisco de Paula pergunta, ele queria, na verdade, ouvir sua opinião sobre o uso do Dinosaumab no hiperparatiroidismo primário e por quanto tempo utilizar.
Oh, Francisco, thank you. Thank you for listening and making that comment. It's a wonderful question. And it's a logical one after what I just said. In the context of hyperparathyroidism, you could argue that Dinosaumab would be a really great drug because it's going to block rank ligand and allow that excess PTH because of hyperpara to be more anabolic. And actually, there are 2 papers now that have been published that speak to that point, in which Dinosaumab treated in women who had osteoporosis and hyperparathyroidism compared to women who had osteoporosis without hyperparathyroidism. The individuals with hyperparathyroidism actually had a greater increase in bone density with Dinosaumab than the ones without. So we don't have a lot of data, and I would love to do a study. I would love to do this study because my hypothesis, which would be, I think, yours, it should be a really good drug for hyperparathyroidism to improve bone density.
Excelente. Muito obrigada, doutor. Eu estou com dificuldade de abrir meu vídeo, mas pelo menos você está me ouvindo bem. Uma outra dúvida. Você solicita marcadores de formação óssea para acompanhamento dos pacientes em uso de anabólico?
Yes, I think the question is what happens with bone formation markers when you follow them with an osteoanabolic. Yes, the Remodeling data, of course, are clear. The bone formation markers go up quickly, and by 6 months, even as early as 3 months, they're coming down. Now, with teriparatide and abaloparatide, they go up very, very quickly. If you measure P1NP 1 month after teriparatide or abaloparatide, they will be higher than baseline. And this is what I don't know. How high do they go? They go up 2-3 times the baseline. How long do they stay up? And when do they start coming down? This is very individual. And so I don't think we can say 6 months later, 12 months later, 24 months later, but at some point, the bone formation markers are going to come down. And that has been my clue to say, well, now we should start thinking about switching to an anti-resorptive.
Tem mais uma pergunta aqui, que haveria algum espaço para a terapia combinada teriparatida e denosumab?
Yes, another great question. Yes, there's a rationale for using Dinosaumab and teriparatide together. And this is a very good question. It follows directly from my lecture. There is a problem because in the United States, I would find it very difficult to get approval for both drugs. But let me give you and leave you with one last thing. I have a physician who I take care of, and he said to me, Doctor, I want to take Dinosaumab and teriparatide. And I said, well, yeah, I understand why, but you're never going to be able to get it. He said, Doctor, I will get it. And he did. He actually got it. And he has been, he used that combination for 2 years, and now he's just on Dinosaumab. This man has had a 30% increase in bone density of the lumbar spine in 2 years. So that's just one patient. I'm not saying it would be for everybody, but it's a very interesting idea of combination therapy. And I think for very severely osteoporotic patients, if you can get it approved, I think it would be very reasonable.
Dr. Blesinck, eu tenho mais uma pergunta aqui. Você usaria teriparatida por mais de 2 anos ou Romo por mais de 1 ano?
Well, with Remodeling, no, I would not use it for more than 1 year. I don't, you know, the drug seems to be a 1-year wonder, you know. After 1 year, you're dealing with an anti-resorptive, and who knows what else you're doing. So I think it's a 1-year drug. With teriparatide, again, as I said, I do like the idea of using it for more than 2 years, but it all depends on whether or not their bone dynamics are still confirming a positive effect of drug. And if I'm still seeing a positive effect of drug, I'll use it. I don't worry about osteosarcoma. I never have worried about osteosarcoma. And now there's no reason to worry that using it for more than 2 years would be a problem in that regard.
Perfeito.
Ok, Dr. Blesinck, eu acho que vamos encerrar aqui. Eu nunca ouvi uma aula do Dr. Blesinck mais ou menos. Todas são grandiosas, são fantásticas. Em qualquer lugar que ele vai, ele carrega uma multidão enorme. E espero saudosamente vê-lo no Brasil em breve. Então, te agradeço muitíssimo, 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 e boa noite e agradeço a todos.
Muito obrigada, Dr. Blesinck. Foi excelente a aula, realmente muito boa.
Well, thank you for inviting me to join you tonight. And I look forward to the time when I'll be able to join you in Brazil, and we'll all have a good time together.
We will. Thank you.
All right. Bye-bye.
Thank you. Bye-bye.